Welcome everybody. My name is Alan Tay. I'm right at the bottom of the left corner of the screen here. And thank you all for spending your afternoon to participate in the 21st SJMC Grand Rounds. Okay, 21 already. So if you don't want to miss any of our future Grand Rounds and live webinars, please hit the subscribe button and notification bell so that you will be informed when we are about to go live. Okay. So now this session is on breathlessness on exertion. Could it be heart failure? And the presenter and moderator is Dr. Yap Lok Bin, right at the top there. And the panelists are Dr. Kanan. Hi, Kanan. And Dr. Navid. Okay. All right. So without just some housekeeping before we forget. You can, if you're watching on YouTube, you can use the YouTube commenting for asking questions, but whatever questions will be answered only in the Q&A session at the end of the presentation and discussion. We would also invite you to join us at slido.com. 3145997 is the code. If you use that QR code scanner, you will go to Slido and you can ask your questions there as well. Okay, but they'll only be answered at the end of the session. And you'll be entitled to CPD points using the MMA app to scan. All right, and it will again be only displayed at the end of the session. Okay, so without further ado, I'm going to switch over the slides to Dr. Yap. So over to you, Dr. Yap.
Thank you very much. So I'm Dr. Yap. Today we are going to go through a topic of a symptom that we encounter very frequently. So as a cardiologist, quite frequently we are referred patients breathlessness, could it be a cardiac cause? And the format of today's presentation will be 3 cases of interesting cases that I've actually seen recently, starting from clinic or the ward of breathlessness. And so for each case, I will invite our panelists to comment on any of the symptoms and signs that they would like to know, the investigations, and then we'll work out the diagnosis. So let's start with case number 1. So I recently saw a 43-year-old man, previously well, no past medical history, complaining of 1-week history of breathlessness, chest tightness, also associated walking up the stairs. So he's otherwise a professional, works in logistics. He does not have any history of smoking. He has not been away anywhere traveling. He has not lost any weight. Okay, he's still mobile, he's doing a bit of exercise. So examining him, blood pressure was okay, 140/90. Heart rate normal, 75. Oxygen saturations 97% on air. His JVP is not raised. Heart sounds are normal. Lung bases were clear. There's no ankle edema. So I start in the clinic. He has this summary and ask Dr. Kanan for any comments. Is there anything else you would like to know about before we start to do some investigation?
Okay, the usual risk factors, diabetes, hypertension, hyperlipidemia, does he have any of those?
Nothing.
Nothing. And family history, nothing to...
No family history.
Okay. Smoking, I think you said he's a non-smoker, isn't it?
Mm.
Yeah. All right. So I suppose if you listen to this story, the most likely diagnosis you will entertain is coronary artery disease. This is based on the clinical history. Your examination, you say that was essentially normal. So other things that will cause chest tightness and exertion related to the heart, things like valvular heart disease, you would think that's rather very unlikely. And most times Pulmonary heart disease, clinical examination should pick it out, except for uh, occasional instances where you got severe aortic stenosis, you can miss it. If someone has got mitral stenosis, it's possible for you to miss it if it's very tight. So other things are things like hypertrophic cardiomyopathy. You may have certain signs and symptoms. Um, more likely signs like a parasternal ejection systolic murmur. You might get a double apical impulse, or you might hear a fourth heart sound. And none of this has been present in this person. So there's something else to think about. Then, of course, often we miss severe anemia. Even when you look at the conjunctival, might not look pale, and then when you do a blood test, you find that they are quite anemic. So that's the other thing to think about in someone like this. Then we may have to work backwards. Um, Blood pressure is 140 by 90. So to me, that's borderline and probably not enough to explain his symptoms. If we exclude cardiovascular causes, then it's reasonable to consider a respiratory cause like bronchospastic disease, like asthma. The patient may not have any clinical signs when you examine the clinic, but it could be that. It could, if you're subsequently gone on to investigate the heart and found nothing very much, something related to the lung, I think you want to think about. But I must say that looking at the hemodynamics that you have presented, looks rather very stable, saturations look very good. So my initial evaluation of this patient, I would not think of anything very serious.
Okay, thanks. So I didn't think there was anything very acute here, but since the patient has come to clinic, we have to exclude anything serious in terms of cardiac. Okay, so I'm thinking maybe do some tests, at least ECG, echo, maybe a CT scan to investigate for coronary artery disease. So I'm going to show you some of the initial investigations here. So one of the first things is make sure he's not having a non-STEMI or MI, so the troponin is negative. We talked about anemia, his HB is good, renal function is normal, and of course, nowadays we always check for a COVID test if we're not sure, negative. So nothing much on his routine blood test. So the next thing is we do an ECG. So maybe Dr. Navin can comment on some of the investigations that will show.
Thanks, Doctor. Okay, I don't see anything very remarkable on the ECG. You can see it's sinus rhythm. There's some T inversions, fairly non-specific. It leads 3 AVF and also V3. Lead 2 looks normal, so nothing very significant here. Maybe a bit of left axis deviation. Other than that, okay, I mean, the T inversion in leads 3 and AVF can be a normal variant, but it's good to do some further tests to look at one of those differentials that we were thinking of.
Yeah, so it doesn't look like a acute MI or
Yeah.
even any ischemia. And then we'll move on to evaluate further with the echo. So I'm going to show you the echo now.
Okay, so echo again, on the left side we have the short axis view, and on the right side we have the 4-chamber view. Okay, so looking at the short axis on the left side, you can see all regions of the myocardium are contracting normally. Right? I don't see anything else. Am I missing anything else that maybe Dr. Kanan, you want to comment? But the one on the right side, you can see that the right ventricle appears to be slightly enlarged. I don't have a Doppler here to see if there's a significant regurgitation across the tricuspid valve, but from my initial eyeballing, I can see that there's no regional wall motion abnormality to indicate coronary artery disease, but the right ventricle just appears to be slightly dilated.
Can I just clarify for the audience, if you think the right ventricle is dilated, what might cause this?
Okay, well, when you have dilated right ventricle, you're thinking about increased pulmonary pressures, such as in pulmonary hypertension. Either it's something acute, or it could be chronic. So then, of course, we need detail, like what you mentioned earlier. A CT scan, looking at the pulmonary vessels may be useful at this point in time. Your initial investigation, there was no D dimer, then it was just a troponin, right?
Yeah, I didn't check a D dimer or ENP.
Because if you're thinking of something acute like pulmonary embolism, then a D dimer might be useful in those instances.
Yeah, agree. So,
So I think just to make it interesting, if you take it from the time that Dr. Yap saw this patient at clinic, I certainly would not have done a D-dimer. I certainly would not have thought that. Just going by clinical science, because I think, especially when you're out in practice in the clinic, all you have is your stethoscope and your hands and everything else. So I certainly would not have thought the lung was likely. The heart rate is very good, blood pressure is good, the saturation is very good. So I don't think I would have done a D-dimer certainly.
yeah, I agree, Dr. Kannan, because I used to do D dimers a lot, and then I found that every other patient that came with breathlessness, I was doing D dimers, DMP, and all that.
Right.
So now I just keep it a bit simple first and then take it from there.
So the only reason I would consider a D dimer in this patient is because looking at the right ventricle being
After the echo.
slightly dilated,
Yeah.
then to exclude pulmonary embolism. So it's not a routine test like what you mentioned earlier,
So
but
you
based
do
on
it
the
after the echo, right?
correct after
yeah,
the echo.
That I think is reasonable.
Yeah.
Yeah. Yeah.
So next, I'm going to show the CT scan because what I had done following seeing the echo and the ECG, and we still didn't have a diagnosis, was to order a CT of the cardiac with the contrast, which means that we can see part of the lungs and also the heart, especially the coronary arteries. So summarized here are the images for the coronary arteries on the CT. Navin, you want to say it's normal or abnormal?
Yeah, I mean you've got a very good images here, and you can clearly conclude that the vessels are normal. But all three the major coronary arteries are normal. There's no obstructive lesions there.
Okay, so on the same CT that was done, I think we'll skip this because we already talked, Dr. Kannan has already talked about possibilities. We will show you the CT scan of the lung now, and Dr. Navin can comment. We can repeat the cycle.
All right, so very interesting. If we can play this video again or pause it, we can see this filling defects within both pulmonary trunks. Those are that. Maybe Yap can just point it out. Yeah, you shouldn't see this filling defects here. So definitely this is very suggestive of bilateral pulmonary embolism. You can see it within the both pulmonary trunks. So it's very surprising that this patient is fairly stable in presentation. He's not tachycardic, not hypotensive, good saturations, not very typical presentation because I would assume someone with bilateral pulmonary embolism would be probably be a bit more ill on presentation. Yeah, but it's good that as part of the CT scan, besides looking at the coronary vessels, we can also assess the pulmonary vessels for, in this case, we can exclude pulmonary embolism, and also we can look for any lung parenchymal disease.
Okay, great. So at this point, we have confirmed that the patient has pulmonary embolism. Okay. In view of that, we actually did further work.
Can I just
Yeah.
ask for the sake of interest?
Mm-hmm.
When you do a CT angiogram, okay, let me tell you what I'm guilty of. When I do a CT angiogram for looking at coronary artery disease, I just look at the coronary artery. I probably very cursory glance at the aorta, if I'm suspicious of something clinically. Otherwise, I might not even look at it very thoroughly. And I'm certainly guilty of not looking at the lump most of the time, unless clinically I suspect something, that I look at the lump. So I'm totally guilty. So if I had done this case, I would have completely missed the pulmonary embolism. Was there any reason for you to look at the pulmonary arteries? Is that a routine practice? What can we learn from you?
Okay, so I think because of the fact that we are getting a lot of patients with chest discomfort and breathlessness, which can be non-specific, one thing that I think we should have a quick look on the CTs. In a patient with chest pain, apart from coronary disease, have a look at the aorta, have a look at the pulmonary.
To make sure there's no PE aortic dissection, and also to have a look at the lungs. Sorry, we're just adjusting the volume a bit. As well as the lung parenchyma, especially in patients with breathlessness, because you can often see fluid overload, fibrosis, or even consolidation, pneumonia. And so I think the CT is quite useful to have a general look around the chest, chest area in the heart. I mean, for me also it's a routine thing. It's part of my assessment. I assess part of the aorta that is visible, the pulmonary trunks, and more often than not, we picked up a few cases of aortic dissection or aortic aneurysm, or in this case, pulmonary embolism. So I also look briefly at the lung tissues, but if I'm not too sure about what I'm looking at, then I usually get one of the radiologists to have a second look at it. Okay, so now that we know the patient has pulmonary embolism, the next question that most clinicians will be asking is why, So was there an initial DVT that led to this? The answer is we did the ultrasound and no, there was no evidence of DVT. Is there a form of thrombophilic tendency? So we did a thrombophilia screen as well. I mean, this took a few days for the results to come back, and the answer was no. Since we have a hematologist here, Dr. Allen, I don't know whether you have any comments on thrombophilic screening in pulmonary embolism.
Yeah, sorry, I tried to troubleshoot the audio. I apologize if the audio is quite bad. I'm not sure why, but there's a problem with the speaker conference microphone. I think there's some feedback. I'm getting feedback. I think if you can cut down the volume in your earphone, because I can even hear it without the. Okay. Right. Okay. Is that better, Ivan? Yeah, because I think it's picking up feedback from even the earphones sometimes can be very loud. It can come up. Yeah. So I apologize for that. I hope it's better now. Anyway, from the hematologist point of view, in somebody who is breathless with clear lungs, which doesn't mean likely like a pulmonary institutional disorder like pneumonia or heart failure, we have to make sure the patient is not anemic, okay? Or, of course, we think of pulmonary embolism. But a bit unusual here is this man was not tachycardic. His heart rate was only 75, so it wouldn't have come to mind. Yeah, I'm not sure what the volume problem is. Hang on. Let me check the audio. Yeah. Okay. Yeah, it seems to be recognizing. Is it all right? Some echoes, is it?
Are we muted? The ones?
Yeah, you're muted. You're muted. So let me check the. Yeah, it's the power, the anchor conference microphone on. Yeah, I can't adjust anything now. But pulse oximeter is not reliable. Some patients may have even normal pulse oximetry, and they can't exclude pulmonary embolism. D-dimer is useful, but mind you, it's a very sensitive test, and there could be false positive D-dimers from inflammatory conditions like pneumonia, trauma, and so on. Okay, but in this man is how old again? 43. 43 is sort of middle age, not young or not very old. I would, you still need to look for an underlying cause to see there's something which had provoked the pulmonary embolism. So is history taking, which is important, long travel, long haul flights, mobilization of any sort, and etc., and drugs, and so on, especially women who are all contraceptive pills. But in this man, also he's not that old, so to look for inherited cause, a family history is very important. There are also some acquired causes in the adults, for example, autoimmune antiphospholipid syndrome. But in older adults, we are concerned about mitotic lesions or cancer as an underlying cause of thrombosis. So any alarm symptoms like weight loss, change in bowel habit, etc., I think should prompt one to look for an underlying neoplasia. So these are just my thoughts.
If we have done all the things that we've done so far, I think there's a role for at least some sort of like CT evaluation of the abdomen. Like you mentioned, malignancy, so there's things like lymphomas or carcinomas in the abdomen, and then you find that, your ultrasound or low limbs might not pick up anything, but on the scan, you might pick up.
Maybe we take off the mask. I think the sound is partly due to that. I'm not sure, but so take up your mask.
Any better?
To sound better? Is it what echoes or what? Background noise. It might be something wrong with the microphone. I've checked the audio settings and speaker microphone. I can't change anything now.
Okay, can you just go on?
Yeah.
Okay. At this point, we've got a patient with pulmonary embolism. No primary cause for the identified yet. We are going to treat the patient. He was seen by a hematologist, and we decided to put him on taxane initially, and then put him on a novel anticoagulant, in this case, rivaroxaban. Okay, and he was fine. He was discharged and still quite well now. Now, because this is a relatively new experience that we have putting patients with pulmonary embolism on NOAC, I just briefly mentioned that there are 4 available NOACs: apixaban, dabigatran, edoxaban, and rivaroxaban. And in some situations, we'll give subcut taxane or fondaparinux. And so very briefly, we have a regime depending on which novel anticoagulant you should choose, as listed on this slide. I won't talk too much about this. I don't know if Dr. Allen has any comments on this.
Hang on, man. I am still... Okay, I've cut down the audio sensitivity. I cut down the audio sensitivity. I think it was too high. The microphone level was too high. Yeah, apologize. So I think it was picking up every background noise, including playback on the next door. Okay, sorry. I think in this day and age of novel oral anticoagulants, it made life a lot easier. In the sense that your warfarin, we have been struggling with warfarin and trying to establish a good INR level. It takes time. That's to come back for frequent INRs to get the right warfarin dose. And actually, the studies have shown that early good anticoagulation is important to prevent late
complications. So I think the NOACs have helped a lot because it's actually a single dose and you don't have to worry about delayed effect of anticoagulation. And it's simple, either once or twice a day. I think no matter what the pharma says, there's little to choose between any of them, except that maybe some people may prefer single-day dosing and maybe there may be compliance issues. The other thing to be wary of is the renal function. Some of them, there may be over anticoagulation if there is renal impairment. So just be careful, especially in the older adults. The proviso about NOACs is they are still not established as the best anticoagulation in patients with antiphospholipid syndrome. So, or in such conditions, we prefer higher intensity anticoagulation. So warfarin is still preferred in antiphospholipid syndrome. So for this gentleman, we have to make sure it's not that. If so, then we would switch to warfarin rather than NOAC.
Doctor, this is a case of unprovoked pulmonary embolism, right? So what would you suggest be the duration of anticoagulation?
See, first of all, whether there any underlying cause. For example, if there's malignancy, then you really have to address the underlying cause. If the underlying cause is correctable, then, for example, if it's malignancy is a potentially curable one, then it may not be, then you treat as long as the malignancy is active. And once the patient is well in remission, if you at least treated the pulmonary embolism for at least 6 months, you may be able to stop.
Okay.
But if it is something like antiphospholipid syndrome, we generally don't stop unless the titers, the antibody titers drop. Okay, so we may leave these patients on longer term. If it's very life-threatening, unprovoked pulmonary embolism without any known cause, some people will leave it on long-term anticoagulation also. So that one is it's a conversation you have to have with the patient.
Yeah. Because this is a fairly young gentleman,
Yeah.
and then to convince him to be on anticoagulation for long-term or even lifelong, maybe a bit of a uphill task.
Yes. But I think you still have to go through the motions of trying to identify an underlying cause for this unprovoked PE.
Okay, thanks. So I think we will move on to the second case. If there are any questions, maybe we can answer at the end of the session. Okay, so this lady was referred to me by a consultant gynecologist. Okay, she has been having a history of heavy menses previously for the several months leading up to this presentation to the hospital. She had 2 days of mild breathlessness, I would say, because she's able to walk around actually. Now she's known to have fibroids in the history and previously been anemic, but otherwise no other medical problems, not on regular medications. Has 3 children and hemodynamically stable as well, as you can see from the vital signs. JVP is not raised, no ankle edema. Now, there's concern about heart failure from the gynecologist. So I was asked to assess this lady as well as help with the treatment of anemia. I think I'll show you the blood test and then maybe ask Dr. Kannan to comment. So this is the blood test result for the lady. Dr. Kannan?
I mean, looking at the hemoglobin seems unbelievable. I mean, it's 1.7. I think the only times I've seen 1.7 is in my days in the University Hospital, and that's going back more than 24 years ago, when we used to see the occasional orang asli, and that too when I was a medical officer, not later in my career. So I don't know whether it's a lab error, because 1.7, and you look at the heart rate, nothing to talk about. Look at the blood pressure, nothing to talk about. All those 1.7s, I've seen the heart rate to be in excess of at least 100. I mean, I don't know. You cannot compensate. So I've got some doubt as to the number that we see there. But be that as it may,
I assume the patient would have been pale and other clinical signs would look for. I mean, here, I mean, there's a history of menorrhagia. So once there's a history of menorrhagia, you see this in someone this age, they're not going to look around for anything else. There are no prizes for this one. I suppose the only thing I want to look at is if you are thinking anemic for a while, whether there's any renal dysfunction. And short of that, I think we take the blood, correct the menorrhagia.
Maybe Dr. Allen, you represent our lab in SJMC. Is this any comments on the result?
Clinical correlation. If the patient looks very, very pale, the lab is probably correct. My record is 1.6 grams in a lady who had chronic iron deficiency and then developed an autoimmune hemolytic anemia on top of that. And then she rapidly decompensated, came to ER looking like white, pale as a sheet, hemoglobin 1.6, and the MO was panicking away. And this lady is probably, starting to decompensate from a very chronic iron deficiency, and you can see the parameters. The key thing is the MCV. Okay, the MCV is very low. The red cells are very small. That the only couple of things, either iron deficiency or thalassemia syndrome. Now, thalassemia syndrome don't deteriorate like that by itself. So this is actually deteriorating chronic iron deficiency, probably from menstrual losses because of the history. Until you reach a level, she is starting to become symptomatic. I've seen patients walking around with 3 grams, 4 grams. And I had a lady whose only chief complaint was, I can't run the marathon as fast as I used to. And she came to the clinic with a hemoglobin of 4. Yes. Yeah. So they can be very well compensated.
So I was joking with the patient. I said, your HB is 1 point something. I've never seen so low. And she said, I can drive a car still. So, but anyway, we were doing a workup to make sure there's not any signs of heart failure, because that was a concern for fluid overload on transfusion. So I have an X-ray and an echo. Maybe Dr. Navin can just tell us any abnormal or normal.
Well, again, eyeballing, I think the heart looks slightly enlarged here. If you look at the cardiothoracic ratio, right, appears to be slightly enlarged. Bit of upper lobe diversion, maybe some curly V lines, which is suggestive of pulmonary edema. You can see these transverse lines within on the right side. I could be imagining it now that I know the possible diagnosis, and patient could actually suffer from heart failure due to chronic anemia. So from what I can see, in a nutshell, the heart appears enlarged. Bit of upper lobe diversion. You can see this haziness bilaterally, and some curly V signs, which could correlate with pulmonary edema or pulmonary congestion due to heart failure.
Yeah, but no pleural effusion. That's nothing.
Yeah, there's no pleural effusion.
So here's the echo.
Again, I'm very pleasantly surprised here looking at the images. Again, the short axis and the 4-chamber. The heart is contracting very well. Normal ejection fraction. The chambers are not dilated. So it's a normal echo study.
Okay. So we are fairly happy there's nothing severe in terms of heart failure. I think she's saturating well, and we want to now treat her. Maybe Dr. Allen, how would you transfuse patients with such severe anemia? What kind of regime would you propose for blood transfusion?
Okay, before you consider any transfusion, make sure you send off all the blood parameters for ferritin or iron panel, folate, B12, etc. Because once we transfuse, that will affect the results. The issue is, should we transfuse at all? Generally speaking, nowadays for iron deficiency anemia, even those who are moderately severe, right down to even 4 point something, 5 grams, which are very well compensated, not very symptomatic, just like giddiness, that sort of thing. I don't give blood transfusion. In fact, the recommendation is not to give blood transfusion, but to give iron. And the choice of iron, if you want a rapid recovery, is intravenous iron. So instead of giving blood, we would nowadays rather give intravenous iron. And the rate of rise I've seen is as fast as 1.5 grams, sometimes even 2 grams a week. You can get that kind of increment. So some doctors will be panicking, HB5, why are you not giving blood? You know, it can cause, actually, they don't go into heart failure. Sometimes the hyperdynamic state or anemia may simulate heart failure changes clinically and on the X-ray, but they're actually very well. Only exception is sometimes people with underlying coronary artery disease, or if you worry whether there is some potential source of blood loss, maybe a peptic ulcer, the patient got a history of melena on and off. I don't think we want to take chances and maybe would give blood because if the reserve is very low, 4 grams or something, if they have a sudden bleed, then it could be quite disastrous. But in somebody very, very symptomatic like her, I think with 1.7, there's not much reserve and something disastrous could happen also. So it's not unreasonable to give blood, but sometimes they can be tipped over into worsening heart failure. So I would give it slowly. Normally we would give maybe 1 unit a day with fusimide as a cover, and then the second unit the following day and that sort of thing. Don't rush in the blood all in one day.
So the message is
the other thing is giving blood does not correct the iron deficiency. So it only corrects the hemoglobin. So you still need to give iron, preferably intravenous, if you want a faster recovery.
Okay. Any other comment?
One of my arguments was, I noticed that furosemide was given. I mean, if I examine this patient, there's no evidence of heart failure. Look at X-ray, I agree with Navin, the heart looks a little bit, but I thought the lungs look very clear. And this is someone who has lost blood, so there's volume loss. So in volume loss, I don't think I want to give furosemide. I mean, I think just replace the blood. She has lost volume, so just replace the blood. I mean, if you're worried, maybe give Paxil. We often find that occasionally, even for someone who comes in with GI bleed, you can give furosemide. I think that seems to be really very wrong. So I think someone like this, I'll be quite comfortable if blood is going to be given, give the blood. I mean, like Alan said, don't rush in everything on the same day. But just give blood, I don't think you need any diuretic.
I think this goes clinically, the JVP is okay, you're not like the standard neck pain.
So before the examination, we said the examination is pretty good. So someone like this, you don't need.
Yeah, we also do this blood marker, pro-BNP, which is a marker of heart failure. Was it elevated or in this patient?
No, I didn't do a BNP for this lady because she was looking quite well, and we just went ahead to treat her and gave a little bit of.
I guess this patient is lucky because I did have another patient in her 50s who actually had menorrhagia due to fibroid, has been seen by the gynae team, advised for removal of the fibroids for many years, but she presented with full-blown heart failure. She had lung congestion, her heart was enlarged. So I would consider your patient very lucky in that sense. Despite I always thought a hemoglobin of 1.7 is incompatible with life, but this lady is walking around very well, driving on top of that. Yeah.
So, in summary, an interesting alternative presentation of breathlessness that we've all, come across. So I'll move on to the third case for the sake of time. We've got a bit of discussion as well to do. So she's very interesting as well. Recently seen a 64-year-old lady who came to clinic, 2-month history of breathlessness and chest discomfort. And actually, I also started off not very sure, so we had to explore further. In addition, she was not well, having headaches. She said she has been having high blood pressure at home, but no previous medical history of hypertension, never was on any medication. She's a housewife, doesn't smoke. Examination, blood pressure is high, 180/100. SATs is okay, 98%. JVP very minimally elevated. Lungs had a little bit of soft crepitations. So
maybe heart failure, I wasn't sure. Any other things you would like to know, Dr. Navin, or you feel you have some provisional diagnosis here?
Well, I mean, when I see this history and a patient presents with such elevated high blood pressure, then of course I'm thinking of pulmonary edema, or has the patient developed cardiomyopathy due to uncontrolled hypertension or undiagnosed hypertension over the years. Besides that, I think it's any chest pain? No chest pain. Oh, she has chest pain as well.
Yeah.
So the other possible diagnosis, if she has coronary artery disease and now she's developed some form of dilated cardiomyopathy. So these are my thoughts. Those are the cardiovascular causes. Then of course we have to also think about underlying pulmonary causes, such as lung fibrosis or bronchiectasis or something along those lines. Yeah.
Okay. So as with the first case, I had a provisional plan for workup, ECG, echo, and then we'll see.
Can I just interrupt? I think maybe for the general practitioners out there, we see someone like this. If they talk about the first, before we used to see the medical students, I think of 10 differential diagnoses in someone like this. Number 1, number 2, number 3, number 4 will be hypertension with hypertensive heart disease. I probably will not think very far beyond that. I see a blood pressure of 180 by 100 in someone who's 64 years old. My money will be on hypertension, hypertensive heart disease, and left ventricular failure due to markedly elevated blood pressure. Then Navin brought up about underlying coronary artery disease. That certainly could be there, but the first thing is the hypertension before we start chasing other things.
So we do an ECG and echo first, I think. I agree that that's not a bad place to start looking. So I'll show you the blood test, and for the sake of time, I think nothing unremarkable here. Okay, fairly unremarkable. So
yeah, it's so lowish, isn't it, Aaron? 11.6.
Borderline.
Borderline, yeah.
So, any comments on ECG, Dr. Kannan?
Nothing very exciting.
No
very
LVH.
mild ST segment depression. I think it's 2, 3 years. Could be something, could be nothing. Very non-specific. Otherwise, I'm looking for left ventricular hypertrophy, and I certainly can't find any criteria for left ventricular hypertrophy. I think it's probably normal. So, for hypertensive heart, nothing much here to support it.
So I'll give you the echo.
Looks very good. I'd be more interested in the numbers when we measured the diameters of the ventricular walls. What numbers did we come up with?
No LVH.
No left ventricular hypertrophy. So, was that blood pressure reading just one, or has she had a history of high blood pressure not controlled in the past? Was she scared to you?
She does not have a previous history of high blood pressure, but over the last few weeks, she has been measuring at home, and it has been high.
Do you remember any numbers?
160, 170, 180.
So the reading you got is not you, just you frightening us.
Yes.
Okay. If hypertension is the cause of a problem, there's no evidence on the ECG, there's no evidence in the echo, but we certainly have seen patients with, if the blood pressure rise has not been there for a long period of time, so that there's no time for the heart to develop a left ventricular hypertrophy. We certainly have seen a heart looking like this, and yet the patient is in pulmonary edema. It could be just diastolic dysfunction, could still explain it. I think cardiac chamber size, just eyeballing, looks normal on both sides.
I think the other thing is the diastolic dysfunction that we commonly see in this age group, especially those with hypertension.
Yeah.
So of course that will need more detailed discussion. So, but generally looking at this echo, I agree with Dr. Kannan. Nothing really outstanding there. Yeah.
Okay, there's one point which I put in the slide, which that she has significant PR. Her peak pressure is high, 63. So that may suggest some evidence for elevated right heart pressures here. Yeah. So a bit like what we discussed, pulmonary hypertension. but not huge, her right heart on the ankle. So just some soft signs there. She's too breathless to do a stress test. I would have liked to do it, but I thought because her right heart was possibly showing some signs of pulmonary hypertension, we went ahead for a CT to look at the coronary arteries.
Can I fight with you here a bit, just for fun? If I saw someone like this in the clinic, and then, I saw blood pressure reading like that, I probably would have treated the hypertension, and probably the cardiac CT and lung CT, all I would have left for later if she's not improving. I mean, that's what I would have done. I probably would not have done the same CT. What would you have done? I mean, those blood pressure numbers are very high. I mean, you see quite commonly. You just treat them for hypertension, you send them home, they come back, they say they feel better.
Yeah. I agree with Dr. Kannan. I mean, that was one possibility. But again, probably we did not see the patient clinically, so Yap would have been the person seeing the patient. And probably the patient was fairly breathless for him to do this test, If she was having very mild symptoms, yes, I agree with Dr. Kannan. I would just stabilize her blood pressure and then later bring her back and see how she's doing. So correct me if I'm wrong, Yap, she must have been quite breathless during her presentation that, you decided to carry on with the lung CT.
Yeah, but actually significantly breathless, very concerned. She wanted to do everything possible to find out. But interestingly, I'll show you the scans. So first of all, this is the CT cardiac, looking at the coronaries. Maybe Dr. Navin?
Again, say fantastic coronaries for a 64-year-old. So right coronary artery is normal. Left anterior descending, LAD, you can see just a calcified plaque there, but again causing very mild disease. And the left circumflex is normal as well. So nothing remarkable here to suggest coronary artery disease as a cause of her symptoms.
So mild coronary artery disease, yeah? Okay. So nothing that can explain her breathlessness really. So this is the video of a CT chest. So Dr. Navin, see what changes you can see in the lungs.
Okay, so again, here we can look at the pulmonary vessels. Like the patient that we discussed before, you don't see any filling defects within the pulmonary trunks. But even though I'm not a radiologist, looking at this lung, you can see that there's a lot of white patches there. Maybe Yap can just point it out as we play the video. Right, bilaterally, you can see those patches, more obvious on the left side. Yeah. So this could suggest underlying lung parenchymal disease as a cause of symptoms. Whether it's something acute like pneumonia or something more chronic such as lung fibrosis, that's a possibility. So I think that's my opinion.
Yeah, so we got a radiologist report which basically said that there are interstitial changes in the lung parenchyma, which suggests pulmonary fibrosis. Okay, so now it looks likely that her mild coronary disease is not causing her symptoms. It's more likely that she has pulmonary fibrosis. And again, in view of this, we want to know what could have been the underlying cause. Okay, so further investigations need to be done. Any comments from panelists about what we should do at this point?
Yep, just to enlighten the GPs. I mean, lung fibrosis, as part of the clinical findings, some of the patients may have clubbing. So maybe this is a thing that you can also look out for during your physical examination, for the interest of the GPs. Anything like that?
Yeah, no, she did not have clubbing.
All right. Okay.
So even though we found pulmonary fibrosis, a significant thing that we should treat is the blood pressure, isn't it? I mean, treatment for pulmonary fibrosis, from what I know, it's quite dismal. Nothing magical that we have. But blood pressure is certainly can treat and might give us some
relief of the symptoms.
Yeah.
So I had a
respiratory physician come in to help me because of the pulmonary fibrosis. The CT scan was discussed further, and actually there was some lymph adenopathy seen. So as part of the evaluation, we also wanted to make sure that there was no evidence of underlying TB, which could have caused the symptoms as well, or what are the other possible causes of pulmonary fibrosis. So I will cut this short because this all took a matter of about 2 weeks. She had a lymph node biopsy. The result was unremarkable. TB PCR was done. That was negative. And then she had a whole series of blood tests. And I just summarized what was interesting here was that she had an elevated ESR, low C3, normal C4, and a very strongly positive ANA, which would suggest one of those diseases as listed there, SLE, scleroderma, rheumatoid arthritis, connective tissue disease, and also an anti-double-stranded DNA positive strongly. So she was referred to a rheumatologist who felt that she was likely to have SLE and started on treatment. So not bad. Well, we got there in the end. I think it took quite a while. So to summarize our 3 cases, and also to see if there's this further discussion.
Was there any cause found for the gentleman with the pulmonary embolism? Was there any underlying cause?
No.
Just idiopathic.
No, we treated, he was better, and he's under follow-up. There are no online questions.
Yes, there is one on Slido. In fact, there are 2. Hang on. Okay, let me change the share screen to Slido. Give me a sec. Once again, apologize for the audio. My Chromebook had a firmware update, and then suddenly the audio settings all changed. So I couldn't find where to change the microphone sensitivity. Okay, first question on the Slido is, oops, it disappeared. It's a JVP of 2 cm significant. Are you on the phone?
Depends on where you.
You are the one who put it up there. What is +2?
+2 from the upper sternal edge.
Is that the upper limit of normal?
Upper limit of normal, isn't it?
Yeah.
From my memory of cardiology examination, about 2 cm is about.
Yeah, I think so.
Seems normal.
Yeah, okay. It's normal.
The second question I think is probably directed at me. Would you consider thalassemia in the second case of anemia? How old was that patient?
About 60.
60, you don't get thalassemia major presenting for the first time at the age of 60. You could have somebody with thalassemia minor, and then it deteriorated because of something like severe iron deficiency. In fact, but thalassemia minor by itself would not deteriorate. It would be a stable hemoglobin, either normal or slightly low. It doesn't get worse with time. It's something we tell patients. But one of the things we see time and again is patients with thalassemia minor, they get worse due to iron deficiency. Typically women, it's very, very common. And then GPs are afraid to use iron because they have this concept that thalassemia, you get iron overload. But actually these women are iron deficient, and then they don't get iron tablets, and the anemia gets worse and worse and worse. It's like you just have to give iron. We cannot exclude thalassemia minor in this condition because both of them, they look the same with microcytic anemia, MCV low. But when you correct the iron deficiency, if microcytosis persists, MCV persists, then you may be able to check and see whether the patient has got thalassemia minor. But doing hemoglobin electrophoresis at this point in time, it will be masked by the iron deficiency, so not recommended. So treat the iron deficiency first. Again, just to remind that blood transfusion does not correct the iron deficiency, because I've seen a few people, microcytic anemia, scoped and everything, given blood and then sent home, and the iron deficiency is not corrected. So it will recur. Third question is,
Yeah, before that, we have a clear history of menorrhagia in case 2. So, I mean, no point to get a lot of other things.
yeah.
Menorrhagia is there, so I think I'll put that.
There's a third question in Slido. How sensitive is resting ECG in detecting pulmonary embolism?
Very poor, actually. I think I reviewed this some time back, and we presented case of pulmonary embolism, something like 30% or less. I mean, if you look for the classical, ECG, which is going to be even more infrequent. But simple things like, sinus tachycardia is what we expect. I mean, I was very, very surprised that the patient had nothing. Patient wasn't on beta blockers, for example. Yeah. Your patient with pulmonary embolism was not on beta blockers for some reason.
No.
So it's very, very surprising. I feel like Navin pointed out that, I mean, the pulmonary embolism is certainly not mild. I mean, major vessels, things like that. Right? I must say that all of them I see at least tachycardia. So, I mean, that's probably, and your F12333 is it's almost like an afterthought. You look for it and then you see, work back from the CT scan rather than you pick it up directly most of the time.
Yeah.
You can have pseudo anteroseptal infarct patterns because of RD overload. You can see right bundle branch block actually occurring. Those things you see, but very infrequent.
There's a question from Dr. Sunita. What's the role of BNP in heart failure and or cardiac biomarkers?
Well, I think in acute heart failure, very helpful. We have shown a series of cases where patients have breathlessness and it's very difficult to tell from the start. I think it's a quick way to screen for heart failure. So there have been a few patients I've seen where even looking at the X-ray, I'm not quite sure whether this is heart failure or not. We have checked BNP. We also look for infection with CRP, and they do give you a clue. So elevated BNP is quite helpful, I think. For example, I just give you an example. This week, I saw a patient that was referred by an oncologist. He said, I gave this lady chemo and I'm worried that she might be developing heart failure. And I saw the X-ray, and the X-ray did show some shadowing in both lung fields. I wasn't sure. We did an echo, we did a BNP, we did a CRP. And the BNP was normal, but the CRP was mildly elevated. In fact, we felt that the patient didn't have heart failure. The respiratory physician saw the patient, did a CT scan, and they actually found that the patient had pneumonitis, which was possibly due to medication or infection. So that's a situation where I think the BNP can be very helpful when you're uncertain. In someone with very obvious LV dysfunction, EF is 20%. I think the value of doing BNP maybe is limited. We already know the patient has heart failure.
It's a question.
If I may add, so I suppose NT-proBNP is something I would do where I'm not sure whether heart failure is the cause of patient's symptoms, but I would certainly want to consider heart failure, then I would do it. So that's consideration. And somebody who's overt heart failure, I would not do NT-proBNP except for observing progress of treatment as we introduce various drugs. Periodically we check in some patients to see the NT-proBNP progressively dropping. That's what we do that. So yeah.
Yeah, I agree with Dr. Kannan, Dr. Yap. I usually do proBNP if I'm in doubt of the diagnosis in an acute presentation. It'll be good to, for us to rule out coronary causes or is it a pulmonary cause. So that's where BNP is useful. And then, like what Dr. Kannan said, to monitor the treatment, is the patient actually improving? And also, I think it's a prognostic marker. If your proBNP is very high, I think it's a poor prognostic marker in patients who have heart failure. And I think she also asked about cardiac markers. The second question, something about
What cardiac biomarkers? Yeah.
okay. Well, I mean, again, cardiac biomarkers can be elevated in cases of heart failure, but again, they are non-specific. So we don't routinely do unless we're thinking of, the heart failure is due to coronary artery disease or something like that, but we don't routinely do cardiac biomarkers in patients who are presenting with heart failure, because then, the troponin might be elevated, but it doesn't really mean anything and doesn't alter the management of this patient.
There's one question from Dr. Keshab. I think none of us are respiratory physicians, but the question is the use of steroid inhalers the only treatment for pulmonary fibrosis, and do they help? I think from what I know, the treatment of pulmonary fibrosis, particularly the autoimmune side, will be systemic steroids and not inhaled steroids. So if I'm not wrong, we don't have any respiratory doctor here in our panel. And so generally, I don't think they are useful. So it's systemic steroids as far as I know. There are some new targeted drugs for pulmonary fibrosis also, but again, it's not in my area, so I can't comment about that.
I think again in this patient, like what Dr. Allen said, systemic steroids, because the main cause is actually SLE.
Yeah.
So that, of course, the treatment is going to be systemic steroid. So that should improve her symptoms, I think, rather than inhaled steroids.
There's one cause of non-cardiac breathlessness we do see now and then. It's actually acidosis. And sometimes we caught out acidosis, and I mean, common one, the renal failure, maybe quite obvious, but we miss some acidosis due to septicemia. I think some patients just become acidotic, and then nothing, and it's actually a patient turned out to be septicemia. And the other one, which I'm just reminded, maybe just to share with audience, sometimes we see now is what our endocrinology colleagues warn us to look for euglycemic diabetic ketoacidosis if they are on SGLT2 inhibitors. So the blood sugar isn't very high, but they're actually diabetic ketoacidosis. So something to worry about. You see somebody who's breathless, air hunger, lungs are clear. Something like that.
The clinical signs give you a clue. I mean, the lungs are absolutely clear, you're still very breathless. So I think about acidosis, of course. Yeah.
Okay. Let's see any other comments from the questions. I think that's it, And it's actually, we are hitting time already, 3 o'clock. So we are now going to go to the most important part, which is the QR code for point. Give me a sec. Okay, so whip out your MMA app, all right? And this is the code, which will be active for about an hour. If I generate it correctly, it should work. Yeah, you got it. All got your points? Remember, this is the new CPD cycle. So 1st of July this year to the 30th of June next year, you need to accumulate at least 20 points for you to apply for APC 2024. Okay, this point won't go towards APC 2023, which is actually dependent on your points accumulated from 1st of July last year to 30th of June this year. So it's every month we'll be having some presentation, and so do join us. Don't forget to hit the subscribe button, notification bell in YouTube, so that you'll be informed of our next live stream. Okay, so we hope you enjoyed the session. I've enjoyed participating even as a non-cardiologist. Thank you, a bit more to contribute this time, but I think it was a great talk. So thank our panelists, Dr. Yap, Dr. Kanan, and Dr. Navin, and most of all, thank you all for listening. Apologize once again, got the audio all mixed up, but I think I know what now. You know, every time there's always something new when they do some computer update, so they change the layout for the microphone insensitivity. So we do learn something each time. So do scan for the points. We'll leave it on. You can actually play back and still get to see the QR code on the video. All right. So without further ado, we wish you a happy weekend. Okay. So hope everybody is well, healthy, happy. All right. Bye bye.
I also learned